Good evening. I'm very pleased to be invited to moderate today for the Migraine Multidisciplinary Summit. And we have an interesting program. We have migraine in family medicine, and then we have newer medications in migraine, and then we followed by women and migraine. I am really happy to be part of this, and I thank Abby for giving me this opportunity. And I would like to introduce our first speaker, Mohammed Fergali. Mohammed Fergali is professor at in the Dubai Medical College here, and he's a senior specialist at Dubai Health Authority and a member of UAE National Diabetic Guidelines Committee. He is a member of DHA Diabetic Board. He's a senior lecturer at Dubai Medical College, and he has lots of paper and lots of interest in diabetes, headache, bronchial asthma, hypertension. His CV, if I read, I think it'll take me 10 minutes. So without much delay, we are very interested to hear about migraine in family practice. Actually, migraine patient, either they go to the pharmacy just in the road or they go to primary care. The floor is yours, Mohammed.
Thank you very much, Mr. Chairman, for your kind introduction. It's my pleasure to be with you here tonight and to talk about migraine. I'll just start with my disclosure. I have nothing to disclose, no conflict of interest in introducing this presentation. And I just start with the prevalence in Dubai population of the migraine. So the episodic migraine headache, it's 18.2%, and the chronic migraine headache is 2.5%. The frequent episodic tension headache is again 18.5%. I start with the programs which we are introducing to the market in Dubai, and we are talking about migraine and best practice. So the first line treatment and management of acute migraine versus the preventive treatment for migraine. So the non-steroidal anti-inflammatory drugs represents the highest prescribed medication in the primary care, because sometimes the access of innovative medication is limited to primary healthcare physicians. The second line treatment is triptan therapy for the treatment of acute migraine attack. The third line management with the Gepants and dietans for the treatment of acute migraine attack. The first line treatment for the prevention of migraine is beta blocker, angiotensin II receptors blockers, or anticonvulsant for the prevention of migraine. We have the second line treatment, tricyclic antidepressant, and the third line treatment. Then we have the third line treatment with the other medication, which is the anti-CGRP, which is a new medication coming to the market, and the monoclonal antibodies, emergent treatment for migraine attack, and the healthcare cost by treatment lines. These KPIs always we distributed to the market in order to get the best practice, and we request all healthcare providers who are practicing or treating migraine to upload for us this data. If I talk about the real data from Dubai, we have around 50,000 patients in 2020 who are complaining of migraine. In 2021, we have 54,000, and in 2022, we have 61,000 who are complaining of migraine. And the number of patients who treated with migraine are 68% in all through 3 years. If you look to the patient split based on ICD-10, based on the type of migraine, so you have migraine without aura constitutes the highest, then migraine unspecified, followed by migraine with aura, chronic migraine, and other migraines. So this is the type of the migraine which we are facing, and according to their prevalence in overall migraine numbers of patients. If you look to the medication, and again, if I classify the medication, I'm just now setting the scenes of what is the practice in Dubai. So you have the total number of migraine patients with treatment during the measurements here. You have 30,000 patients with migraine treated, and the 37,000 in 2022. The non-steroidal anti-inflammatory, again, the percentage of patients receiving non-steroidal anti-inflammatory are 47%, triptans are 34%, dietans and diptans are 37 to 36%, beta blockers 15%, and the calcium antagonist and anticonvulsant only 6%. Then if we are talking about the new medication and the new era in the management of migraine, which is the anti-CGRP, it is only 4% in all through the 3 years, 2020, 2021, 2022. Now, what's about the prevalence of migraine worldwide? We have 1 billion people worldwide affected by migraine, and people affected by migraine globally represents 14%, 19% prevalence among women, and 10% prevalence among men. It is the 6th most prevalent medical condition worldwide. If you look to migraine, it is the 2nd leading cause of disability worldwide. It followed the first line or the first disease area, which is low back pain. The migraine-related disability in 2016, migraine caused 45 million years lived with disability. This was 5.6% of all years lived with disability globally, second or behind to the low back pain. Migraine ranked first among people aged 15 to 49 years, accounting for 8.2% of the total year lived with disability. This is a very important point to look at, because if you look to the migraine and the affected population age between 15 and 49, you know, this is the working or the active age group. And if the migraine people, they will have, it will affect their quality of life. So it will be reflected on the indirect cost. So your patient will be either will not go to work or not go to school. And if they go to school or go to work, they will not be productive. This is what we call the absenteeism and the presenteeism. Again, it is leading level 3 cause of global years lived with disability. So headache disorder is second to low back pain, and whether it is in male or in female. So when to suspect migraine? There is recurrent headache of moderate to severe intensity, more than 90% of people with migraine. Visual aura is 30% of people with migraine. Family history of migraine in 50% of people with migraine, and the onset of symptoms at or around puberty. As I mentioned, starting from 15 and to 49, this is the age common where you have the high prevalence of migraine. If you look to the migraine, it is a complex chronic characterized by frequent attack with neurological effect. So it have 4 phases. The prodrome, few hours to 1 day, the aura, 5 to 60 minutes, 4 to 72 hours, you have headache and associated phase of migraine attack, and 24 to 48 hours, which is the post-prodrome. Each one of these, it have symptoms presented by the patient. Not all of them can be present in one patient, and sometimes there is an overlap between all these symptoms throughout the migraine. So there is several known risk factors that migraine can develop. So you have 2 types of risk factors, as all of us know. There is the non-modifiable risk factor and the risk factors, and the modifiable risk factors to develop migraine. Family history, being female, hormonal fluctuations, age, and socioeconomic status, all these are non-modifiable risk factors. But there is in our hand some modifiable risk factors which we can work on with counseling and educating our patient in order to reduce the frequency and the risk of getting migraine. Obesity, snoring and sleep problem, comorbid pain condition, head and neck injury, major life events, smoking, caffeine intake, depression, and down the list. All these cases are modifiable risk factors you would like to deal with when you are dealing with a patient with migraine. What is the disease progression? You have the episodic migraine is more common than the chronic migraine. 91% of migraine cases are episodic and the 9% are chronic migraine. The episodic migraine is low frequency episodic and less than 8 headache days per month. High frequency of episodic migraine from above 8 to below 15 headache days per month. Above 15, this is what we call it the chronic migraine. So we have either episodic migraine, 91% of cases, and the chronic migraine, which represents 9% of cases. Aura occurs in 25 to 30% of patients with migraine, and aura, mainly you have the visual symptoms. There is partial loss of sight, blurred vision, flashing lights, wavy lines spot, and monocular blindness. Other symptoms include pins and needles, numbness, tingling, speech disturbance, vertigo, dizziness, and many other symptoms which can be presented in the aura. The diagnosis of migraine, record medical history, and apply diagnostic criteria, consider differential diagnosis, especially when you differentiate between migraine, cluster headache, tension headache, examine patient to exclude other cases, and use of neuroimaging only when necessary. Not in every case you would like to go for neuroimaging in order to diagnose migraine. Migraine can be classified, as we mentioned, as episodic or chronic, and according to the International Classification of Headache Disorder, there is the diagnostic criteria of migraine, 5 or more attack fulfilling the following: headache attack lasting 4 to 74 hours when untreated or unnecessarily treated or unsuccessfully treated. Headache has 2 or more than following symptoms: unilateral location, pulsating quality, moderate severe pain intensity, aggravated by physical activity during headache, more than one of the following: nausea or vomiting, photophobia, or phonophobia. The episodic migraine, when an individual with migraine has less than 15 headache days per month. The chronic migraine, more than 15 days per month for more than 3 months, on which more than 8 days per month meet criteria for migraine, which we talk about according to International Classification of Headache Disorders. There is migraine to diagnose. In chronic migraine, there is number of headache days can fluctuate monthly. There is always difficult to diagnose, requires many months of headache data, can be impacted by medication overuse, difficulty of identifying distinct attack of headache days when migraine lasts more than 1 day, and complicated definition of migraine attack. So the challenge associated with the diagnosis is always there. Migraine is distinct neurological disorder and it should be with other primary headache. You can be confused, but in migraine, moderate or severe intensity, which is a type of pain, unilateral, 4 to 74 hours, 72 hours, variable frequency, nausea, vomiting, photophobia, phonophobia, pain aggravated by activity, affect 2 to 3 times more women than men. And the tension headache, in the other hand, it is mild, moderate intensity, press and tightening, bilateral versus unilateral, 30 minutes to 1 week, variable in frequency, and precranial tenderness, phonophobia and photophobia can be present, not aggravated by activity versus the migraine, and the more common in women than men. The differential diagnosis, again, the migraine without aura and the episodic tension headache. This is again what we talk about when you differentiate between the migraine with aura versus the tension migraine. Patient education and patient centricity, always the role when we are talking about chronic disease. So provide appropriate reassurance, agree on realistic objective, identify predisposing and or trigger factors, and individualize therapy according to symptoms and needs. Always in treatment, in chronic migraine, you would like to individualize in management and which disease, which type of medication can fit the persons according to patient characteristics. So the migraine management should involve both acute and preventive treatment. The acute treatment taken at the first sign of attack. Always we say, don't delay to start the treatment of migraine. Don't tell the patient to wait and see. They have to start the medication which can abort the attack as early as possible. Minimize the relief and emerging symptoms as they occur. Preventive treatment taken regularly by those with frequent migraine attack proactively reduces migraine frequency and severity and duration. The migraine can be treated using two strategies, acute and prophylactic treatment. And for acute treatment, the characteristic abortive of symptomatic first choice for initial treatment may provide symptoms relief, possibly for moderate or inconsistent benefits to reliability issue, medication overuse, headache. Remember this term, medication overuse, headache. In prophylactic treatment may reduce frequent severity and duration of attack, disability, and healthcare resources utilization, including cost. Efficacy can be limited, including therapy proposed for the therapeutic area. Most are associated with issues of patient adherence. So the guideline recommendation to use the preventive treatment in those with more than 2 migraine per month. They offer treatment more than two attack per month. Attack do not respond to acute treatment, and the frequent or long use occur. Quality of life, business duties, or school attendance are severely impaired. And this is what I can say about the quality of life and how this affects the patient. The decision to initiate preventive treatment should be discussed with the patient because you are going to give long-term indication. Consider treatment if contraindication to failure or overuse of acute treatment, adverse event with acute treatment. Offer treatment 3 to 5 attacks per month and moderate severe disability, or always offer treatment if more than 6 attacks per month. The acute treatment, non-steroidal anti-inflammatory, acetyl salicylic acid, diclofenac potassium, ibuprofen. More than 3 consecutive attacks without treatment success, triptan, sumatriptan, rizatriptan, and ilitriptan. Then more than 3 consecutive attacks without treatment, you go to gaptans or dietans, either the urogaptan or rimigaptan and lisiniditidine. The unmet need associated with traditional acute treatment, tolerability issue, up to 43% of patients experience adverse effect within 24 hours, recurrence, 67% to 82% of patients experience return of pain within 24 hours, and overuse of many traditional acute therapies, and the cardiovascular contraindication, and approximately 2.6 million in the US. So in certain medication, you can't give if patient with cardiovascular disease. So what do headache patient want? Explanation of their disease, pain relief, role in decision making. So acute treatment, preferred process, faster onset of action, longer duration of action, lower adverse event, and lower price. Expected outcome, rapid pain relief, complete pain relief, return to normal activities, no recurrence, and no adverse event for the treatment. In preventive treatment, the preferred process, higher response rate, fewer adverse event, less frequent dose regimen, and higher convenience. In expected outcome, cure, symptom-free, reduced headache frequency, reduce the headache severity, and improve quality of life. This is the main aim, the main objectives when you are going to treat acute or preventive treatment. What about the overview of acute pharmacological therapy in the treatment of migraine before the CGRP-based therapies? The goals of acute migraine, specific acute migraine triptan, and when you are going to use the principles of acute migraine treatment, non-specific treatment, non-steroidal anti-inflammatory, analgesic, and antiemetics. This is the treatment be used before the era of CGRP, which started in 2018. CGRP-based therapy, a new era after 2018. There is the monoclonal antibodies and the GPANs. All of them are available in the market according to our rules. So you have per medication, you can see whether it is used for acute or used for preventive treatment, and you can see that whether it is available in United Arab Emirates or no, and whether to use as episodic or chronic treatment. Atogyptan, you can see it is available in acute treatment, and it will be available for treatment in UAE very soon. So the acute treatment used in migraine, up to 40% of patients are dissatisfied with their acute treatment. Reason for dissatisfaction include lack of treatment, success, and safety, tolerability, and concerns. Only 22% of patients use a migraine-specific acute treatment. This contributes to the socioeconomic burden and can promote migraine chronification. Initial treatment is selected based on individual patient needs. The patient should be treated early in the attack with an adequate dose and formulation of the medication. Non-steroidal anti-inflammatory and the triptan are standard treatment and can be used individually or in combination. Ideally, acute therapy should be restricted to no more than 2 to 3 days per week to avoid medication overuse. Long-term use of acute medication is associated with medication overuse headache and the transformation from episodic to chronic migraine. Acute therapeutic temporary abort headache symptoms and do not prevent recurrence. Inconsistent efficacy and slow onset of action. Use is limited, contraindication, and use is restricted to 2 to 3 days. By the way, if we are talking about the role of primary healthcare physician, sometimes when you step up in management of the headache patient, especially for the chronic headache or the preventive treatment is not available for primary care physician to prescribe it, and at that time there is no need to keep the patient beside you, but you have to refer to the neurologist who is eligible to prescribe this medication. Now we are talking about new policy in drug prescription, and we are recommending in acute cases the anti-CGRP to be prescribed in acute cases by the first line or the gatekeeper at that time in order to have a weapon, in order to improve the quality of life of our patient as soon as possible. If we are talking about anti-CGRP, they put it as third line, but it is an alternative first line. Now in our guidelines, which is coming to the market, and I'll show you the consensus of Emirates, it is alternative first line according to patient characteristic. So the prophylactic treatment of migraine, we talk about it. and the prevention migraine treatment, again, we talk about this, but the unmet need in old migraine prophylactic treatment, for some patients, prophylactic migraine medication may reduce migraine frequency and severity. However, prophylactic treatment is often underused, as prophylactic 2/3 of eligible patients do not receive it, as again, the access to medication and the limitation of this medication to be prescribed or privilege prescribing for primary healthcare physician. Common reason for oral prophylactic discontinuation include lack of efficacy and intolerable side effect. If you look to the follow-up treatment response and failure, effectiveness of acute medication, pain freedom at 2 hours after treatment, sustained pain freedom at 24 hours after treatment, and the pain relief at 2 hours after treatment, effectiveness of preventive medication, episodic migraine, more than 50% reduction from baseline on monthly migraine days, or monthly moderate to severe headache days. Chronic migraine, more than 30% reduction from baseline in monthly migraine days or monthly moderate to severe headache per days. Adverse events, incidence, severity, and treatment related, and adherence, the degree to which the patient behavior corresponds with the agreed recommendation from the physicians. So you set the plan of management with your patient, individualization in management, and the secure patient compliance with the treatment. The recommendation for acute treatment from different guidelines, again, it is almost the same as we mentioned. And the most important point for acute migraine, it is recommended to use the CGRP as an alternative first line. European Headache Federation consensus for acute treatment, again, talk about the same. And if you are talking about European Headache Federation guideline for migraine, again, 2022, talk about, again, the same, to consider the CGRP as alternative first-line treatment option. You shouldn't go step approach if you can improve the quality of life of your patient by giving the medication, which giving a response to your patient in very short time. European Headache Federation, again, continue to say the same. And if we are talking about, this is the UAE consensus, use of the CGRP in migraine prevention, and again, whatever the available drugs and whatever the use, with the main recommendation today, non-steroidal anti-inflammatory to start with, again, which is available, the tools available for the primary care. But as I mentioned, we are changing the policy, and we are going to mandate that in acute cases, if you have a drug which you can prescribe and abort the attack and improve the quality of life, you go for it as first line. Thank you very much for listening, and thank you, Mr. Chairman.
Thank you, Mohammed. So many points and so much information. I'm sure we will address this in the question and answer sessions at the end of the talk. Thank you very much for putting them all together in a nice order. I really admire the way you have talked about many things in migraine. To
Thanks very
proceed
much,
with
Mr.
our
Chair.
next speaker, I want to introduce Dr. Mona Thackeray. Mona Thackeray and me are working together for the last more than 20 years. She got her MBBS and MD from Nagpur University. After that, she did Doctorate of Medicine and DNB in Neurology from Mumbai Hospital. She also has specialist certificate in neurology from the Royal College of Physicians, UK, and also she is fellow of American Academy of Neurology. She has worked in Rashid Hospital, Al-Zahra, and then now she is recently in Parkview Hospital. She has produced a lot of papers. Her last paper was in the World Congress of Neurology. So I'm very proud to introduce her. She is always an interesting speaker. She's going to speak on new migraine therapies with innovative mechanism of action. So she's going to talk about what is latest in the treatment of migraine. Mona, the floor is yours.
Thank you, Dr. Kotekar. Thank you so much for introducing me so well and a very kind introduction. And thank you, Abby and IVPN, for giving me an opportunity to present. And thank you, the audience, to coming late evening to listen to our talk. And let me move my slides. Yes. So these are my disclosures. So Dr. Fargali has set the stage for the migraine, and thank you for that. It was beautifully done. So my job is a little easier. So when we have a patient of migraine, how do we treat these patients? So we have to give him pain relief. We have to stop the acute attack, and we have to prevent the second one coming. So we have to have a two-pronged approach for migraine treatment. Now, why are we having newer and newer medications coming in every time? Because there is so much unmet need. And the unmet need starts from patients actually not being diagnosed. And in this CAMEO study, which was a longitudinal web-based study, it was a population-based study in the US. And it included about 11,000 plus patients. And in that, they were asked about their migraines and how they were treating, and about the headaches. And in that, you could see that 60% of patients with chronic migraines did not consult any healthcare professional for their migraines. So only 40% did a consultation. 90% were actually misdiagnosed. Only 10% were diagnosed as migraines. And in our clinic, and Dr. Kotekar will agree, many of our patients come and say, oh, we've got sinus headaches for a long time, and my mom has sinus headaches. But actually, they were never sinus headaches. They were actually migraine headaches. And 95% did not ever receive any effective treatment. Only 4.5% received. So there's a lot of unmet need there. The other unmet need, which this CAMEO study revealed, was that 50% plus, about 60% patients had more than one unmet need for acute migraine treatment. So there was about 70% who were severely having severe migraines with severe disability. So they are not able to function with their migraines. 60% were dissatisfied with their treatment because they never got any benefit. 11% had cardiovascular events, so they were scared to take any triptans. 10% had opioids and barbiturate use, which was pretty high. And of course, with all the emergent treatments, even taking 8.7% had to go for emergent care use. And of the patients who are actually taking triptans, this masked study revealed that 38% patients, 55% patients actually discontinued the triptans. And out of the 55%, 38% thought that it never worked for them. So the triptans also not always work. So we need better and better medications and better tolerable medications. 23% had side effects, and we all know that triptans can give some side effects like chest tightness, like fatigue, pain in the neck, pain in the body, lot of fatigue. So triptans are not always without side effects as well. What about the preventive medications? Dr. Fargali mentioned all the preventive medications, and you can see that the preventive medications are effective. So you can see they are all on the left side of the graph as compared to the placebo. But there's always a problem of these preventive old medications, which are repurposed medications. They were actually invented for something else, but were used for migraines as well. They have a lot of adherence problem, about 24%. So 1 in 4 will actually stop these so-called platform preventive therapies. And 12%, around 12% will stop by the end of year 1. And this was also seen in a population-based study in Italy. And you can see that the graph starts going down as the time progresses, and people start stopping all these preventive medications, which could be anti-serotonin, which are antidepressants, beta blockers, anticonvulsants, and other anticonvulsants as well. So there is a big need to get more medications, but it did take some time to come to the CGRP era. And you can see before the 90s, we just had the beta blockers, the amitriptyline, and the flunarizine. And it took about 8+ years to come to topiramate for preventive medication. And then it took about 6 years more to come to botulinum toxin, that was around 2010. And then another 8 years it took for the CGRPs to be approved. And we had the new era of CGRP injections or monoclonals, the erenumab, the galcanezumab, and the eptinezumab, which is available in Dubai now. And then we have the new kids in the block, the GPANTs, the rimegepant and the atogepant will be soon available. And in the acute treatment, before 1990, we did not have the triptans. And 1991 was a revolutionary time when the sumatriptan came over. And then started the triptan era, but it was there till 2002 and then 2008. But after that, in between, we didn't have anything else for acute treatment. And then in 2019 came the very specific lasmitidan. Lasmitidan was being used, but it has come out of favor because it has a lot of dizziness and sleepiness. And you can always only take it in the evening, and you're not allowed to drive for 8 hours after lasmitidan. So now we have the GPANTs available, which can be used for acute treatment as well as preventive treatments. And we have the rimegepant, ubrogepant, and the zavegepant, which is still not available here. And I'll be going through a few of them. Just a few words about how do we select the drugs for prevention. So before the CGRP era, we were depending on the comorbidities. We were depending on the side effects, and we were doing a little trial and error. And then, of course, the patient had to say whether what you want a once daily, you want a twice a day medication. And then, of course, depending on the tolerability as well. So if the patient is very obese, so we used to prefer topiramate. If the patient has a lot of anxiety and palpitations, beta blockers do help. And the patients who have a lot of insomnia or is anxious, amitriptyline works for them as well. But these medications, though they are effective, take a very long time to kick in. So you need to tell the patients that it will take in weeks, minimum 3 to 6 weeks for the effect to start coming. A patient with migraine cannot wait for 3 to 6 weeks for the effect to start. So we needed something really good. And actually, we are in a very, very good era of the CGRP antagonists or monoclonals. So what are these CGRP antagonists? So this is calcium gene-related peptides. So these are incorporated into the meninges, and they have the receptors, and then we have the ligands. Now, what these monoclonals do, they block either the CGRP ligand or the CGRP receptor. And what do they cause? They block the CGRP-induced vasodilatation, and they also have a direct inhibition of the CGRP-mediated pain transmission. So they are very migraine-specific treatment. They are not repurposed medications. So as Dr. Fargili mentioned this, so we have this array of monoclonal antibodies. So we have the injectables, which the first one in the market was the erenumab, and then came the galcanezumab. These are once a month subcutaneous injections. Then we have the eptinezumab, which has come, which is once in 3 months intravenous injections. But not everybody is injection or needle friendly. So now we have the very easy medications, which are the GPANTs. And the first one is the ubrogepant, then came the atogepant is still yet to come, and rimegepant is there in the market. Zavipret is still not available in UAE. Ubrogepant is used for acute attacks, and rimegepant can be used for acute and prevention in only episodic, not in chronic. Atogepant can be used in chronic migraines. So I'll be going a little bit more deeper into these molecules now. So let's start with ubrogepant, or Ubrelvy as it is called. So this was the data after which it was approved for acute pain management. And the two trials was the Achieve-1 and the Achieve-2. And you can see, as compared to the placebo, the 2-hour pain freedom, total pain freedom was 19%, and pain relief at 2 hours was 60%. A total of about 80% plus patients actually get benefit with ubrogepant after 2 hours. So this is a very good relief percentage as compared to the placebo, and this was significant. And the same thing was seen in the ACHIEVE-2 trial as well. And what bothers the patient is not only the headache, it is the most bothersome symptoms. So these patients, if you see, they don't want the light, they don't want the sound, they want to be quiet. So these are called the most bothersome symptoms. So sometimes a very severe nausea kicks in. So to get rid of that most bothersome symptoms at 2 hours, ubrogepant also showed a significant difference as compared to the placebo in both the trials, the ACHIEVE-1 and the ACHIEVE-2. So these patients in the trial were asked whether did they reduce the use of other acute pain medications. And you can see after using ubrogepant, the barbiturate use dropped by 58%, ergot by 93%, triptans by 65%, NSAIDs by 47%, opioids by 80%, and other acute medications by 37%. What happened? So, you could always ask, what was the effect of ubrogepant if the patient was on any other preventive medication? So this is an ongoing trial, and we have the data of ubrogepant with monoclonal antibodies, which is about 193 patients. So this is the COURAGE study. And this was the demographics. The mean age was about 40 years and majority were female. And they were using ubrogepant 100 milligrams with CGRP molecules, which is about 44%. So this was the distribution of the preventive medications. And you can see that patients at 2 hours with ubrogepant and the CGRP showed a very good response. So 64% had pain freedom at 2 hours. And at 4 hours, we had about 85% which had pain relief. So how do you use ubrogepant? So the recommended dose is, it comes as 50 and 100 milligram tablets, and it is taken orally with or without food. So if you take one dose and you don't feel the effect, you can take another tablet as well, and maximum dose in 24 hours is 200 milligrams. In the trials, only the 8 migraine doses were used in a 30-day period. So beyond that, that has not been studied. So what about the preventive therapy? Have we got a better preventive therapy than the platform therapies or the first-line therapies? So we have 2 trials now showing that the newer therapies are way better. And you can see that topiramate was approved for chronic migraines, but as soon as the botulinum toxin came in and we evaluated that the comparative study, the forward study, it showed a significant difference as compared to topiramate. Botulinum toxin is given in the migraine points as, you give it frontally, temporally, and in the occipital and neck area. This is given every 3 months. And erenumab was also compared with topiramate in a randomized double-blind trial, and it showed a significant difference as compared to topiramate in reduction of the monthly migraine days. So we have better options available, and they have been studied in trials. And as Dr. Fargali mentioned, that it is now coming into the guidelines as well, and the consensus says that before this consensus, the CGRP was considered as a third line. So you had to fail at least 2 first-line medications, and they had to be tried for at least 6 to 8 weeks before you could start a CGRP molecule. But now the recommendations are coming that it can be used as a first-line therapy. So let's go to the next molecules, which is atogepant. So atogepant was tried in the episodic migraine. And in this trial, they used 3 doses, 10 milligrams, 30 milligrams, and 60 milligrams. And 60 milligram tablet once a day has been approved for episodic migraine. And this was the trial. So it was done for adults between 18 and 85 with more than 1 year history of migraines with or without aura. And the monthly migraine days were 4 to 14. And the primary endpoint was a change from the baseline over 12-week period. And you can see the results that the average monthly days were about 7, and it reduced by 4.2 days. So more than 50-60% of the headaches were actually less after taking etogimat as a preventive medication for episodic migraine. What about the safety? So you can see that the safety of atogepant with placebo is almost the same. So there are no serious side effects, and the treatment discontinuation was very, very minimal. What about chronic migraine? So that was the episodic migraine, which is less than 8 migraine days a day. And when you come to 15 migraine days, what's the data? So this was the progress study, and it was studied against placebo, 30 milligrams twice a day or 60 milligrams once a day. And 60 milligrams once a day has been approved for prevention of chronic migraine after this study. And you can see the difference that atogepant 60 milligrams once a day was actually significantly better than the placebo in chronic migraines. And that's the efficacy of the atogepant. More than 41% of atogepant treated patients achieved more than 50% reduction in the 3 months average monthly migraine days as compared to 26%. So it was significant. You can see that as compared to headache days, acute migraine medication use days, more than 50% responder rate, quality of life, performance in daily activities, and physical impairment, all was significantly, statistically significant with atogepant 60 milligrams once a day. And in this study as well, you can see that it matched the placebo side effects, and the treatment discontinuation was extremely minimal. So very, very well tolerated drug. What is the other drug which gepant is used for preventive medication? So we have rimegepant, which is approved for episodic migraine prevention after this trial. And the trial design was the same. So men and women aged above 18 years with more than 1 year history of migraines. And they were given rimegepant every other day, not daily as the atogepant. And the result was that it had a significant superiority against the placebo in episodic migraines. And the secondary outcomes were met, except for the rescue medication days, which was not statistically significant. And the side effect profile was pretty much the same as placebo, and discontinuation rate was extremely minimal. And with that, I would like to thank you for your attention, and would look forward for a fruitful discussion. Thank you so much. I think you're muted, Doctor.
Thank you, Mona, for a very interesting talk and going through all the newer medications. I'm sure there will be a lot of questions. We'll move on to our next speaker, Professor Fadi Mirza. He is the medical director of Department of Obstetrics at Latifa Women and Children Hospital. He's a clinical professor at Mohammed bin Rashid University, and is a consultant obstetric and gynecology and maternal fetal medicine, American board certified. Dr. Mirza has primary graduation from Beirut, and after that he went to Tufts University at Boston. After that he did fellowship in fetal medicine in Columbia University, New York, and later on he got American board certification in obstetrics. If I read his CV, there's a lot of things to talk about. He has published a lot of papers, and women and migraine has always been an interesting topic for me. Just if you want to say that migraine in children, both boys and girls have similar migraine incidents up until the age of 10. And after they have periods, then you have migraine incidence going up to 2 or 3 times the male population. So Dr. Fadi is going to talk about migraine in women from menstruation till pregnancy, and maybe even till menopause. So we are all waiting for Fadi to give us light on this aspect of migraine. Floor is all yours, Dr. Fadi.
Thank you very much, Mr. Chairman. Thank you so much for
if you may excuse me, Dr. Fadi, I could see that the background on your side is not showing right. If you wish to just leave and join again with the same link, that would fix it.
We'll just stop the video.
Okay.
Okay. Thank you very much, Mr. Chairman. I'd like to start by thanking the IVPN and AbbVie for inviting me to join you today. I hope my presentation will be a light one, just shedding the light on our perspective. When we tackle migraine in our population, when we tackle migraine with our colleagues from the neurology field, how do we look at things? This is our disclosures. And just a few introductory points. As you may know, more than 3 billion people worldwide have disabling recurrent headaches. And this is data that everyone's familiar with, and it's actually listed by our American college in a publication that I will share with the group shortly. Although tension type headaches is more common, the disability associated with migraine headache is greater and is ranked as the primary cause of disability in women younger than the age of 50 years by the 2019 Global Burden of Disease Study. And actually, for most of us who tackle migraine management in women, be it during pregnancy or menarche or menopause, this is actually typical of what we expect with our patients. It's truly debilitating. This is a typical scenario that we use as obstetricians and gynecologists when we try to decipher the type of headache, because I know we tend to blame migraine for as the most common cause of headaches, but we often have to dig into other causes, and this is kind of what we look at. And I think you are more familiar with this than us. But again, it's his point that we truly stress to our junior residents or junior physicians that not everything is migraine. Look into other etiologies, as we're going to see shortly. Migraine headache preferentially affects women, and I think this is what got me to join you, the esteemed group of speakers today, because yes, it is indeed a women condition. About 1 in 5 women are affected by migraine, compared to about 1 in 15 or 1 in 10 when it comes to men. And indeed, prevalence peaks during reproductive age. And this is why we do encounter it often during pregnancy and during the postpartum period. And migraine headaches requiring treatment are common, as I mentioned, in both pregnant and lactating women. And this is probably attributed to hormonal fluctuations that we will discuss shortly. So when it comes to the prevalence of migraine, migraine is considered the 6th most prevalent medical condition, affecting about 1 billion people worldwide. And when you look at women, you could see the significant discrepancy between men and women, with about with a prevalence that reaches about 20% in women globally. Migraine in women, why? Why is that this discrepancy? Well, we blame it on estrogen. We blame it on the estrogen fluctuations. And this is probably why we see it often during the onset of menarche in adolescents. So in our practices, we see those 13, 14, 15-year-olds coming to us with some menarche-related symptoms. And along the side, they'd be like, you know what? I started having PMS, I started having headaches, and lo and behold, it's migraine. And this is why we start to see decreased prevalence of migraine after menopause, although the transition tends to be marked by significant increase in prevalence of migraine. So bottom line, whenever we expect fluctuations on hormones, we expect a surge in migraine headaches. As a result of rising estradiol levels in pregnancy, 60 to 80% of migraine patients will experience remission in intensity and frequency of headaches by the 2nd trimester. So once again, the transition the hormonal fluctuations that we expect during transitional periods, such as transitioning into pregnancy, we expect a surge in the prevalence or in the intensity and frequency of headaches. But then once the hormones stabilize, usually by mid-pregnancy, we start to see a significant decline in headaches. So again, when we diagnose the patient with pregnancy, the first thing we look at or we ask about in her medical history is any history of migraines. With the rapid fall in estrogen after delivery, migraine headaches quickly recur, once again, due to this hormonal fluctuations. Moving on, what do we expect with this hormonal fluctuations? Just as a summary, we expect it to increase at menarche. So this is a group that we and our neurology colleagues have to be vigilant about. We expected whenever we iatrogenically increase hormones, such as with the use of oral contraceptives. And an important point that I'd like to stress here, relenting headaches, relenting migraines is actually one of the contraindication to the use of oral contraceptives. So as a gynecologist, I'm very reluctant to start oral contraceptives in a patient who reports severe migraine in her history. And finally, we expect an increase during the postpartum period and lactation, and finally, an improvement with menopause. So bottom line, if I want to conclude that period, I would say women are a vulnerable group, women are an unlucky group, and we can blame hormonal fluctuations, especially when it comes to estrogen. When it comes to menstruation, we try to differentiate between premenstrual migraine and menstrual migraines, and the way we tackle them is slightly different. Once again, we look very, very closely at the postpartum and the lactation. So a patient who tells me, doctor, I have horrible migraines during my menses, I've had a horrible first trimester when it comes to migraine, this is a patient that I'm going to be extremely worried about during the postpartum period, and I'm going to be proactive with my treatment. And finally, once again, menopause is a honeymoon period for migraine patients. About 6% of females report migraine after the age of 60, compared to the numbers that we looked at earlier. Postpartum, again, a vulnerable group due to the falling estrogen levels. And I think the way I look at it, it's very similar to our MS population. When my MS patient is pregnant, the postpartum period is a time when I'm extremely worried, I'm extremely vigilant, and I think the same applies to my proactivity when it comes to migraine. Diagnosis, I stressed on this earlier, and I'm gonna deep dive into it at this point. It's not enough to say it's migraine, patient has history of migraine, it's migraine, that's not enough. We have to look into secondary headache disorders, and we're gonna deep dive into some red flags. Secondary headaches tend to have a rapid onset or change from baseline, tend to be severe, can be associated with elevated blood pressure. This is when we start to think of eclampsia, which is a nightmare to the obstetrician, fever. Third trimester, which I don't expect an increase in the intensity or prevalence of migraines, focal neurologic deficits, altered consciousness, laboratory abnormalities suggestive of preeclampsia or eclampsia. These are red flags to the obstetricians that look for alternate diagnosis. Don't blame it on migraine. This is an algorithm that has been put through by the American College of OBGYN. What we do is, the first question we ask the patient is your headache identical to your pre-pregnancy headaches? You tell me you have migraines, is this similar? If the treatment's yes, then probably we can treat as a migraine if we don't have any of the red flags. If the answer is no, the second question I'm gonna ask is, how's the blood pressure? Or is it a second trimester or third trimester gestation? Why? If that's the case, the first thing I'm gonna think of is actually preeclampsia/eclampsia, and this is something that we take extremely seriously. If the answer is no, then I have to look into additional secondary causes of headache. Acute evaluation of headache in pregnancy, besides my clinical judgment, besides my history and physical, what are the other things I'm going to look out for? When it comes to imaging, MRI is our preferred imaging study during pregnancy. And we all agree that gadolinium should be avoided due to fetal toxicity. CT scan, we try to reassure our colleagues, particularly in the setting of the emergency room, that radiation from a CT of the head is considered to be exceedingly low. So if I need to rule out a hemorrhage or hematoma, CT scan can be pursued. So bottom line, MRI and CT scans are often used by us in the evaluation of headache in pregnancy. Treatment, we have a very elegant ACOG publication that tackles headaches in pregnancy and postpartum, and it lists the different medications by alphabetical order. What should we use? What should we not use? What's contraindicated? What's not contraindicated? Long list. And fortunately, there's a long list of medications that could actually be used. This is just another point that looks at the importance of secondary headaches. They reach about 35% in this single-centered retrospective by Robbins et al. So again, just trying to reiterate the point that before we treat a patient for migraine, let's rule out secondary challenges, secondary causes. Now, when it comes to challenges to treatment in pregnancy, an important point to keep in mind is unintended pregnancy in our world is quite common. And some data suggest that this rate reaches up to 50% of all pregnancies. So it is an issue, and it is a common fear among us. So why is this important? It's important for us to emphasize the importance of preconception counseling, as well as to tailor-make our treatment in childbearing age women. And when it comes to treatment, ACOG states, though approved by the US FDA, CGRP receptor antagonists are not recommended in pregnancy or in the 6th month before pregnancy. And why is that? Because some of those have exceedingly low half-lives, so they would need to be cleared before that pregnancy. Hence comes the importance of trying to look at this list and perhaps going for shorter half-life treatments compared among the same family. And here, clearly, the second column, the table 2, would stand out as drugs with shorter half-lives compared to table 1. And this is one of the major considerations that ACOG alerts us as providers to. Additional issue that is concern to us as obstetricians is that those migraines, headaches, can be associated with nausea and vomiting, which in turn can lead to dehydration and electrolyte imbalances. And dehydration is one of the most common causes of preterm contractions, and ultimately the worry about preterm birth and low birth weight. So these are real concerns that we have to worry about while we are considering the treatment of women with migraine. How do we approach the management? The first line are the modifiable risk factors, the sleep quality, the hydration, diet, exercise, reducing stress. Then we move on to the non-pharmacological options. And obviously, I'm not going to go into those. Then we have the abortive and the preventive, and I think we have experts in this. But basically, our approach as obstetricians, when we work with our neurology colleagues, is a stepwise approach from the least invasive to the most invasive. Few points when it comes to precautions specific to pregnancy. We look at the pregnancy category. We try to avoid at all costs those known teratogens, those that belong to pregnancy category X, D, etc. We try to avoid opioids, benzodiazepines. We rely heavily on acetaminophen and paracetamol and NSAIDs. But of course, we often have to go to the acute medications, including the triptans. And when it comes to the triptans, a 2005 meta-analysis that included over 4,000 infants exposed to triptans in utero, there was no apparent increase in major congenital malformations, preterm birth, or spontaneous abortions among triptan users compared with women with migraine not using triptans. Another cohort study, including an addition 432 pregnant women using triptans, again showed no increased risk of adverse outcomes. The data is limited because this is not a drug that is often used in pregnancy, but reassuring data if needed. To touch upon the efficacy, again, we don't have a lot of data on ibrogepant in terms of pregnancy, but we have data in menstrual migraines that show, as you see here, significant drop in the frequency of attack when it comes to pain freedom as well as pain relief. So in the setting of women and migraine, it appears to be an effective drug according to the study. Preventive medications escalation, this is just an algorithm that we often resort to. The preferred method is propranolol, which we use in pregnancy often. Then we have a list of second line treatments, followed by third line. We try to avoid the fourth column, including topiramate, if we can, the monoclonal antibodies, and certainly things such as VPA, valproic acid, just giving the significantly increased risk of congenital malformations, particularly neural tube defects. We get asked a lot about botulinum toxin by our patients, whether it's for cosmetic reasons or medical reasons. And the reassuring news is that it's a large protein, so in theory, it's unlikely to cross the placenta. Very limited data on that, primarily the safety database of the company that has shown no increased risk in congenital malformations, and a prospective study of 45 patients, again, a small study that showed no adverse pregnancy outcomes. Do we like to use it in pregnancy? No, but if needed, we can have this discussion and counseling between us, the neurologist, and the patient. So in conclusion, I think you all agree with me that migraine is a major culprit of headaches in women that represent a vulnerable population. It's significantly more prevalent among women, as I showed you, compared to men. And this has been attributed to the significant role of hormonal fluctuations. And finally, menarche, menses, pregnancy, and postpartum represent a special concern to us as obstetricians. Thank you very much for your attention.
Shukran, Professor Fadi. It was really an interesting journey through the women's life, and I'm sure there will be questions. Already I find 8 questions, so we will have it as a group discussion rather than single persons answering. I'll open the first question. Does 1 minute. Are beta blockers such as nicardipine an option for chronic treatment? Can I ask you, Mona? Dr. Mohammed had to leave to the airport, so I think we will include primary care questions as well in our discussion. So, Mona, do you want to handle this?
Nicardipine is a calcium channel blocker, not a beta blocker.
Yeah.
And it can be used for migraine prevention, definitely. Efficacy data is not a lot of data around it, but small series has shown that it is effective.
Okay. Dr. Fadi, do you use this in women during their pregnancy, or is it a last, you keep it a little later on?
We try to keep it later on. Our approach is really symptomatic relief, but we can use beta blockers in pregnancy, particularly in the setting of hypertension, but also in the setting of migraine as well, definitely.
Our gynecologists, they seem to have, some gynecologists have to be little aware of, they say, bradycardia, fetal bradycardia, and they like to monitor fetal heart sound. Is that necessary if you go on higher doses of propranolol, above 43 times a day?
It's
Do
a
you do
very,
that, or?
I do. It's a very, very, very rare occurrence. It's a theoretical risk. It's something we have to monitor for, but it's something that is exceedingly rare.
Okay, because the prophylactic dose of propranolol for migraine is pretty high. I mean, people start with 10 milligram and 20 milligram. Actually, that's not the dose. At least they should be on 40 milligram 3 times a day or higher. What do you think, Mona? What is your practice of beta blocker in
Yeah, so
chronic
I
migraine?
usually go twice a day, 40, and then if needed, I go to 3 times a day. But a lot
Okay.
of patients, after they are controlled, they come back to once a day, and they're doing actually very well with once a day. Most of them don't want to stop it because it's an excellent drug. Only the problem is it takes a long time to start, and sometimes you get this very severe fatigue and tiredness with these beta blockers.
There are good things about beta blocker. If there is a lot of anxiety and palpitation, it's a good drug. But on the other side, it causes sleep problems. Sometimes even it causes vasoconstriction. And if it is along with, say, you are giving with sumatriptan or other medication, there may be issues. So it is one of the earliest medication used for prevention of migraine. So we have a lot of experience with it. I think I've been using it probably more than 25 years.
Yeah, I
We
prefer
didn't
it in
find any
kids.
serious problem. Yeah.
Yeah, especially in children, when you less than 18, you don't have much options. So I prefer a lot of beta blockers. And recently I had a child who was like 13 years old with cyclic vomiting. And she had this motion sickness. And as soon as she's in the bus and the bus is moving and the school bus takes about an hour to reach the home. So she's doing her homework, reading her books. And these people, when they are in the motion and they're trying to read something, they trigger their migraines. So they are very sensitive. They are having a severe sensitivity to motion. And actually, I just started her a small dose of beta blocker in propranolol, and she's done extremely well.
My mentor, you know him as well, Anand Kumar. He used to use cyproheptadine and cynarazine. Cynarazine is not easily available here. I get it from either Irani hospital or they have to go to India. But I find it very useful. Do you find it useful in children and people with cyclical vomiting?
I haven't used it much. Cyproheptadine we used to use before, but I haven't used. Pizotifen we used to use before, long time back, but no longer.
Flunarizine also, Dr. Ajit is using a lot of flunarizine. He gets
Yes,
it for his
it is.
patients from
When
India.
I was in India, we used to use a lot because here it's not available very easily. It's a very good drug.
Okay. The next question is on obesity by Huda. She wants to know, is obesity-related migraine prevalence or just migraine frequency? What is the relationship between migraine and obesity? You want me to take that, or Mona, you want to talk about it?
Yeah, I think there is a relationship between obesity and migraine. And we do advise our patients to lose weight because it does affect migraine frequency and severity. And in these patients, you need to be careful not to miss out benign intracranial hypertension because that can mimic. And with these obese patients, they can be having this underlying thing. So always look into the fundus and see if they have papilledema.
I would like to know from Professor Fadi, but whenever there is an obese lady, especially a lady with the migraine, first thing I would think I will do a fundus examination or send to ophthalmologist to do an OCT to see if there is any papilledema. Second thing is I'm also worried about sleep apnea because nowadays sleep apnea is coming in a big way. And it is considered a risk factor for stroke, migraine, and many other disorders. So I think in that respect, we can consider that obesity directly or indirectly is a risk factor for migraine. So I think that is probably the answer for Huda. There is one more again on propranolol. Does propranolol can affect migraine patient? I think we have answered that already. So we will go. This is from Usman. Does one's environment have any effect on migraine management? Have you faced any of these issues? I have 2-3 practical issues. Mona, you want to add what about environment or where they work or what
Oh,
they
for
work?
definitely, it has a very big role. I think, we did not touch upon stress and the triggers of migraine. And stress as a trigger of migraine is a very big factor. So your environment does play a role. Apart from the stress, if there are any physical factors, if it is very loud, it's extremely bright, you have the lights coming in, which is the trigger for migraine. Or if it is very, small place, suffocating place, very strong perfumes coming in, all can trigger migraines.
If I can weigh in here, Dr. Katakar, from our experience, we notice, like I said, a major increase during the postpartum period, and part of it is, of course, the hormonal fluctuations, as I mentioned, but part of it is sleep deprivation, stress, the fatigue. I think all of those factors contribute to the migraine predisposition.
I fully agree with you. Bringing up a child and motherhood, I think, is like a double shift duty.
Exactly.
And, I used to take care of my children for a few hours in the night, and so that my wife could have a little sleep or at least few hours. I think it's very important to consider that in migraine. I can tell about 2 things about work and migraine. I had a son of one of our EHS staff actually, and classical migraine. We started CGRP, everything was going okay. And after 4 or 5 months, there is a panic call saying that he is now having relapse. And he came to me, and then I just asked. I usually go through some standard questions. We have a questionnaire bank with us, and I just asked because he was finishing his university when he came. I asked, did you get a job? Did you join anywhere? And he said he was joined the airport and he's having shift duties, and he sometimes misses his medication, preventive medication and all this. So that was actually, I thought, was the reason for his relapse. And then I doubled the dose of the preventive medication and gave a letter to the airport saying that he should be given only morning duties in view of his migraine. And that settled the problem. Actually, the government here is very good. If you write a letter, they always, most of the time, actually, they oblige when you think that, that is the case. The other one was another migraine patient. He always said that the medicines are not working. I changed. He himself once told me that his car park in where he's working is far away, and then he has to cross and walk for 10 minutes, and it is in sunlight because he has to go afternoon back home and come back. And he felt that the sunlight was the cause, and I agreed with him, and I told him to wear sunglasses, and I requested the company to give him car park near the main door, and that actually settled the problem. So sometimes you think of very small things, but these small things may be very important in a particular patient. So I feel that each migraine patient is different. So you'll have to talk to that patient and the most bothersome symptom. I can tell you many stories about most bothersome symptom. It's not just the headache. So I think if at all I want to tell anything to the audience, I want to tell that migraine is not just headache, and it causes disability and many other symptoms. So if that will answer the question that work and environment is very much necessary. I ask people not to use their bedroom. Nowadays, we have this tendency to use the bedroom as a dinner place. You eat in your bedroom, you chat in your bedroom, you play on your mobile in your bedroom, and other than what you should do in the bedroom, you do everything else. So I think that should be warned, and specifically because certain light waves, specifically green and blue, if you have a TV in your bedroom, that will disturb the melatonin and your sleep cycle will be disturbed. So you should go to your bedroom just to sleep, and anything else you want to do, suppose you didn't fall asleep, you feel like reading something or calling somebody, or you want to play some games, just come out, do all that. When you feel sleepy, go back to your bedroom and sleep. I think that's one of the lifestyle
Doctor,
management, I will say.
yeah. Thank you, Dr. Nayak, for helping and answering the question. I just have a question for Dr. Mirza, if you allow me. So, Dr. Mirza, we know that the safety of these or anti-CGRP monoclonal antibody is not well established in pregnancy. However, from a pharmacological point of view and theoretically, those are big molecules. So we know from other therapeutics area in neurology and rheumatology that usually monoclonal antibody doesn't cross the placenta given their large molecular size. So do you think that if we have a pregnant woman with severe migraine and affecting really her quality of life and her pregnancy, would you think that we can try to give her these anti-CGRP despite that we don't have an indication to use them in pregnancy? So this is my first question. And this echo also a question from our attendees who are asking you about these intranasal anti-CGRPs. So would they be safe to be administered in pregnancy?
Very good questions. So I'll start with the second question. I personally don't have much experience with the intranasal treatment. I'll stick to the first one. So yes, I agree with you. They are large molecules, so the risk is very low. But when it comes to our treatment options, we always try to look for data, and we try to resort to the ones that we're most familiar with, most comfortable with, the one with the most studied, let's say. But definitely, we need every weapon against the migraine. And the same thing applies to, for example, anti-epileptics. So when it comes to anti-epileptics, there are known anti-epileptics to be very well established, to have a very well established track records when it comes to congenital malformations. But guess what? We sometimes have to resort to them after extensive counseling of the patient. Why? Because it's the only thing that works. So I think when it comes to these drugs, it's a big balance. It's a big risk versus benefit discussion and counseling of the patients. But yes, we do have to resort to these drugs at times. As you mentioned, some of these scenarios are typical indications.
And doctor, and just another question. So do you think that if a pregnant woman has migraine, so is it genetic? So does this mean that the child or the fetus will be predisposed to have migraine in the future?
Very good question. I think when it comes to genetics, genetics are everywhere, and the predisposition is there. So the answer to patients, and the same thing applies, for example, to MS. Although there's no clear genetic inheritance pattern, but we know that the prevalence of MS in the offspring is higher than the general population, reaching, let's say, about 1%. So what we tell the patients when we get asked that, yes, the risk is higher than the general population, particularly in female offspring. And look at the data. The data tells you indicate a 20% prevalence. And with this genetic predisposition, it's probably higher than that. So yes, there is a genetic predisposition that we have to counsel the patients about when asked.
Professor Fadi, Lubna has a direct question. I think this is related to what we are discussing now. What can we give to a pregnant woman if she has a migraine acute attack?
So I think, I demonstrated this in the table. We always start, with the acetaminophen and the paracetamol as the first line, following the lifestyle modifications. The next step would be the NSAIDs. The NSAIDs, we have to be a bit careful because it's gestation age dependent. So we try to avoid early in pregnancy and during the end of pregnancy because of different reasons that pertain to the fetus. But during the majority of the pregnancy, the mid-pregnancy, we can go for NSAIDs to break that vicious cycle. So that would be our second line. And of course, we go up. But from my experience, for the vast majority of migraine patients in pregnancy, usually these medications suffice.
Okay. So some other thing like some of the headache clinics in Dubai give occipital block or other varieties of treatment. That will be a discussion another time. Have you had experience with that, giving occipital block, Dr. Fadi?
I haven't. No.
Okay. All right.
I
Okay,
have given.
Yeah, Mona, yeah, please tell me.
Yeah, I have given occipital nerve blocks. I think they are the safest, and it's just local injection of depomedrol, which is a small steroid, and lignocaine, which is subcutaneous. So pretty safe and pretty effective.
There is another device called Kefali. I think Mona knows this, that you can put it, especially people who have bitemporal or supraorbital pain, and it is available that you stimulate the trigeminal nerve area and supposed to work in that manner. And some patients definitely get benefit, and it's very safe in pregnancy. So these are the two I would advise as regard this. So there is one more question here. What is the role of Botox for migraine headache? I have seen many clinicians are offering this treatment. Anyone have experience with it? I think, Mona, you can talk and I can talk about this. So, Fadi, in your hospital, anybody is giving Botox for migraine?
No. I mean, my hospital is a women's and children.
Okay.
So
you refer. So I should start a clinic near your hospital, huh?
Yeah, that's a good idea. But honestly, I get asked about this all the time by my patients for cosmetic purposes. So it's a question that I have to answer every single day, but not for migraine.
Yeah, but I think let Mona because I'm running a migraine clinic in the Northern Emirates, one of the only few, and Mona also is very much experienced. I do once a week Botox clinic. For many things, you give it for spasticity, but not cosmetic. We are not licensed to use for cosmetic purposes. That's done by, I think, dermatologist. Yeah, Mona? The cosmetic part.
So, we've been giving Botox since I was in Rashid Hospital 20 years plus. Dr. Jihad used to give it before it actually got licensed. So we've been giving it for a very long time. Pretty effective. Only thing is that you have to bear a lot of injections, about 20 plus injections, but works extremely well. About 80-90% patients definitely do get relief. And usually after 3 months, the effect weans off and you have to do it all over again.
One word of caution, it is only for chronic migraine. That means a patient who is getting 3-4 attacks or even 5-6 attacks, it should be more than 15 headaches days a month. So it is not licensed for episodic migraine. So that's
and doctor, usually is it reserved for, it's a question for you and Dr. Mona, it's usually reserved for patients who are refractory on the available therapies, right? So who failed 2 or 3 migraine therapies.
Second-line medication.
Yeah.
Definitely.
Yeah.
Definitely. Yeah. So
and do we have go ahead, doctor.
Are you reading Maya, this best preventive?
No, but I have an interesting question about the use of SSRIs and paroxetine in migraine. I wanted to ask your opinion, Dr. Kotekar and Dr. Mona, about the use of paroxetine, venlafaxine, and all these SNRIs and SRIs in migraine. So do you think they play a role in migraine management?
Yes, they do. They have a big role, especially patients who have a lot of anxiety or depression associating or triggering migraines. I do start them on SSRIs. And
So
SSRI group or SNRIs, you can use any of them. They're pretty much the same.
So I think here we can also ask Dr. Mirza about the safety of SSRIs and SNRIs in pregnancy. So do we have safety data, and are they safe to be used in pregnant women?
Yes, so we use them particularly in the setting of depression.
Yeah.
And many of our patients use them throughout pregnancy and particularly in the postpartum period. We do have data, we favor some over the other, but yeah, we often have to use them more so for depression and anxiety, but also for migraine.
Professor, it's considered safe, particularly amitriptyline. The data on the newer medication, I think there are another two which can be used. Venlafaxine is one of them, and Dr. Ajit, the other neurologist, each one has a flavor to them. They are more experienced in using. But I have used Dipakine, which causes mood stabilization, but you can't use it in pregnancy or those who want to get pregnant. So I use amitriptyline, which is considered safe in whatever trimester of pregnancy. What do you think, Mona or Fadi? Are you using it in first trimester, for example?
If needed, yeah, particularly if the patient is on it already, and the neurologist or the psychiatrist feel that they don't feel comfortable with the patient coming off it, then yes. And our approach usually in pregnancy is to try to go for a single agent. So instead of trying to add up on the number of agents, if I can control her with a single agent, it's preferred from a fetal standpoint or teratogenic standpoint. But usually with these decisions, it's kind of a lot, and I mentioned this in one of my slides, a lot of pre-counseling, preconceptionally preferably.
There is one question here. What is the best preventive medication in view of CGRP efficacy and tolerance? Mona?
So all the CGRPs, they are more or less the same. So we had the Erenumab, which we have the largest, experience with because it came first, which is Imovic. And then we have the Emgality, which came in. So sometimes if one doesn't respond to one CGRP, we do shift to the other. But I have known, in my experience, if patients fail CGRP class, sometimes they don't respond to the other ones. Also, if you try to put them on GPANs, but it is not a must rule. We do try to shift between them. Sometimes we combine it with botulinum toxin as well. Yeah, but there's no one above the other. And there was a trial between Emgality and Rimegepant, and there was a non-inferiority trial. So it was not above any.
One thing, you can combine CGRP with botulinum toxin. Yes. Second thing, you should remember the newer small molecules like Ubrigepant and Rimegepant. They are for acute, mostly used for acute, whereas the other ones which came like Emgality and Erenumab, they are for chronic. So you should remember. So the mode of giving them, like some people like to take it once in, I have a staff, so she is in the hospital, so she likes to take an IV injection once in 3-4 months, and no need to go to the hospital or forget to take the medicine. So some people prefer IV, some people prefer oral, and it's the same with the triptan, where some people like nasal spray, some people like injection, some people like oral. So some of the medicines have all the forms. Like for example, sumatriptan as a tablet, it is available as a nasal spray, it is available as an injection, subcutaneous. So that is the advantage of that medication, because it is available in all forms. But some of the medicines are not available in different forms. So maybe you will prefer one in view that it is available in different forms.
And Dr. Kotoka, since you mentioned the triptan, we have a question about what is the maximum number of tablets of triptan allowed per day? So can we take more than 2 tablets? And So because of the risk of serotonergic syndrome, so what is the acceptable dose per day
This
of
is
triptan?
another issue. Triptans are not allowed more than 2. So you give a triptan, and after 2 hours or 3 hours, if you feel that your headache has gone down by 50%, there is a caveat to it, then only you use the second dose. If you feel that the headache has gone down by 10%, there is no use of using the same triptan again after 2 to 3 hours. This is one thing. The second thing is, you are allowed to take not more than 8 or 10 tablets in a month. That means, I have seen people getting drug overuse headache with triptans just in 2 to 3 months because they like it so much. I had a staff member actually during the COVID time. He felt that the mask he was using, because he was in the ICU, was triggering his headache. And maybe it's true, I don't know, because of the CO2 retention. But he started taking triptan every day, and he had access to it in the hospital. So, and he had a drug induced headache, and it was very difficult to wean him off from that. So my mention is, you don't use more than 2. You can use 2 if your headache reduced by 50% in 2 hours. That means the medicine is working for you, and then you can use that medicine. The long-acting triptans like elytriptan or noritriptan, they are meant for, Dr. Fadi, I would like to ask you this about the menstrual migraine. You have menstrual-related migraine and menstrual migraine. Menstrual migraine is migraine only during menses, and the other one is only means 2 days before or 2 days after and during. And menstrual related means there is menstrual migraine plus any other time there are migraines. So do you have any medication which you will use for menstrual migraine or preference regarding this?
Not really. Again, we usually start with the typical pain management. We do use triptans often for these cases, but usually when it requires more than that, we just refer them to you guys.
Oh, okay. Mona, what do you do for menstrual migraine? Are you using patches of estrogen patch or anything for these patients?
Not really. Once the CGRPs have come, they cover basically everything. So they cover menstrual migraines as well. So you really, the other one with the GPANTs, you can, if you want to give them as a preventive medication around the period time, we can use the GPANTs around that time as well. So
I'm using the smaller molecule GPANTs, both ubrigipant and remigipant. You tell if only coming during menses, you ask them to take 3 or 5 days during that period and start even a day before the menstrual cycle starts. So you're just giving that 5 days of medication, and each strip is about 8 to 10 tablets. I think ubrigipant is 10 and remigipant is 8. Yeah. So we are allowed to write that, and they will use only during that time. I think that is one of the indications. Even the pharmacies they are not promoting it. I think that's a very good thing. And patients who get migraine while traveling, this is another. I keep this medication in there. I tell them to, along with their shaving kit or makeup kit, I tell them to keep the medicine so that if they develop migraine during traveling, they can take 2-3 days of this, because otherwise the whole travel will be spoiled. I had patients who went and on a travel, and the whole holiday was spoiled because of migraine. So I think you should tell them that they should prepare themselves and take a lot of hydration, water, and keep the prophylactic medicine with them. In that category, these new small medications like ubrigipant and remigipant will be a real good addition to the medicines which we are already giving.
Yeah, especially
you
have to take them in cold pack. So if there are tablets, it's easier for them to take and travel.
Okay.
And we have a question for Dr. Mirza. So you talked about pregnancy and menstruation, but what about breastfeeding? So are anti-CGRP safe in breastfeeding? And we have also a question about the safety of sertraline and paroxetine in breastfeeding.
Yeah. So The latter category, I don't often use it myself. Once again, when we reach that level, I usually consult neurology. When it comes to SSRIs, just because, you know, we have a long-standing history with these medications, we often use them for depression. Yes, we use them in during the postpartum period, both of the drugs. Now, of course, we do have to caution the patients about you know, the risk of withdrawal in the neonate, especially if they were using them during the you know, during the end of the pregnancy. Their babies tend to have a higher chance of, you know, being jittery, having some feeding issues. But from my experience, many of my patients take them during the end of pregnancy as well as in the postpartum period, and, you know, with a good safety records. So to answer you, yes, we use them in the postpartum period.
And we have a recurrent question for you, Dr. Nayak and Dr. Muna, about your experience in trigeminal ganglion block. So for migraine headache. So do you have experience in using supraorbital nerve and trigeminal ganglion block for migraine?
Okay, just to tell you that nobody can reach the trigeminal ganglion. It's not easy, but we do what is called suprapalatine ganglion, which is in the you know, superior turbinate above. So it can be accessed through the nose. So we have a spray, and I think in Rashid, Abu Bakr is using that, isn't it, Mona?
Yeah, but it's more for cluster headaches, not for migraine.
Yeah, more for cluster or supraorbital pain.
For migraine.
And then the Cafali device I told you is, again, it's for it goes over your supraorbital, and there is a supraorbital nerve coming out, and if you have a particular pain in that area, that is one of the things I found beneficial. But the trigeminal ganglion itself, I have not found anybody who is safely able to enter and give in that area. So I think it is better to go for you know, the Cafali device. It's very safe. It's about 1,500 dirhams, and it is very non-invasive, and people like that. Otherwise, you can go for superior palatine block.
Yeah,
If
supraorbital nerve blocks can be done. Actually, that's easy and pretty effective as well.
What is that, Mona?
Supraorbital nerve block, that can be done.
Yeah, that can
to
be.
An occipital nerve block.
Yeah.
So, and we will end with two final questions. The first question about the cardiovascular, the contraindication for CGRP and for ibuprofen specifically can be used in patients with cardiovascular diseases?
Yes, it can be used. So, we have a good study with erinumab actually in cardiovascular disease patients with actually recent MIs. So it was found to be very safe. There is no specific study with the ibuprofen, but we can sort of collaborate. You know, take the
extrapolate
data, extrapolate from the PPRP study.
Yeah, Maya, actually, just to add, you know, triptans, one of the contraindication is if the patient has any ischemic or a strong family history or severe hypertension. And that is one of the contraindication. But that's why the detans came into the market, because it was safe for cardiovascular patients.
Yeah, and here comes the question for you, Dr. Nayak. So do you think that the detan, the lasmiditan, is safer in patients with hypertension and cardiovascular disease compared to the Japan, or no?
We to compare to triptans and other medication, yes. But there is no comparative study, as far as I know, you can ask Mona, between detans and the gpans as regard, because the smaller molecule gpans are considerably safe regarding the any of these trials you may mentioned, HE or the 1 or 2, there were no cardiovascular you know, mortality or morbidity found. So I think compared to triptans, definitely these are safer. But the main problem with the detans is that once you give the medicine, patient cannot drive home. They may feel dizzy. So, I mean, if they come in a car to the hospital, they should call their husband to take them back. So it's very inconvenient as far as I'm concerned. What do
Thank you,
do,
Dr.
Mona?
Nayak. Yeah, I still have one question for Dr. Muna before we run out of time. So, Dr. Muna, do we have comparative efficacy between traditional migraine therapies, like, for example, beta blockers, topiramate, calcium channel blockers, and the new treatment? Do we have such head-to-head trials?
Yeah, so we have with the new head-to-head trial, as I showed with erenumab and topiramate, but between the beta blockers and topamax and all, we don't have head-to-head trials.
Okay. And a final question for Dr. Mirza, from the perspective of gynecologist, if your pregnant woman suffers and complains from migraine headache, what would be the non-pharmacological advice that you would give to her?
Definitely. So as I mentioned in one of my slides, lifestyle modifications is a typical recommendation bias. Minimizing stress, increasing exercise, improving hydration, which is something that many of our women suffer from, whether during pregnancy or outside of pregnancy. Avoiding triggers. I think my esteemed co-speakers touched a lot upon trying to avoid known triggers, whether it's the menses or travel or certain odors, etc., etc. I think this would be my first line.
Perfect. So, and with this, our webinar came to its end, and we answered all of our more than 600 attendees we had today. So thank you for all of you for joining this webinar and for staying with us late until the end of this educational activity. Also, please allow me to thank our faculty. So our wonderful moderator, Dr. Kotekar, thank you for always accepting our invitation. Dr. Muhammad Farghali also for joining us despite his super busy schedule today. Dr. Muna, always it's a pleasure to have you with us. And Dr. Fadi Mirza for your excellent presentation and insight into this topic. Thank you so much for all of you. And please also allow me to thank our sponsor, AbbVie, for supporting such educational activities. And I would like to remind all our attendees that you will receive your certificate of attendance by email within 1 week of today. Also, if you missed any part of this webinar or any previous webinar, or if you would like to revisit all these educational activity, the first Migraine Summit and this one and all the other one, you can revisit these talks by visiting our library, IVPN library, which is available free of charge on our website. Also follow us on our social media platform and stay tuned for more educational activities next week about migraine, multiple sclerosis, and much more. And until I meet you again, stay safe, everybody, and have a good night.
Thank you.
Good night, Maya.
Thank you.
Thank you, Maya. I think you have been always, you are the coach behind the football team, So thank you very much
thank you
for Mona and
Thank
Fadi
you.
and the IVPN team. Thank you.
Thank you. Thank you, doctor. Thank you. Have a good night, everybody. Goodbye.
Good night.